Jovi Wong, who's going to present one case. And before that, I believe it'll be Mohamed Al-Nadi, who's going to give the first case, then Jovi the second. And then I'd also like to introduce Miguel Pimentel, who is currently the Pediatric Vitreoretinal Surgery Fellow and Inherited Disease Fellow with Peter and Elise and Ajoy and myself. And he's also kind of been involved in some of our research and some of these cases and research. And so he's also going to kind of chime in and we're all going to discuss. So why don't we get Mohamed to start?
My voice.
I think Jovi and Mohamed are in the same room, probably.
Yeah, so we'll ask you to unmute one at a time. There you go, Mohamed, you're good. Yep, that's better.
So, can we try again? Do you hear me?
Go for it. Yeah,
Okay.
We can hear you. That's good.
I'm Mohamed. I'm one of the PGY2 here in the program. And I'm privileged today to present with Dr. Moni. And the objectives for the session today, the first one was to understand ways of minimizing tissue trauma during scleral buckle. The second would be to understand the recent advances in the techniques for retinal detachment and to understand the principles to achieve high integrity retinal attachment with giant retinal tears. So we have here our first case, which is a 15-year-old girl with a history of high myopia. Came into the clinic experiencing occasional flashes for 2 weeks. Her visual acuity in the right eye was 20/25, and in the left was 20/100. IOP was normal, normal anterior segment exam in both eyes, and the fundus exam was normal. And the left is showing us this. The Optos photo shows us here a retinal detachment that spans from around 2 o'clock to 6. That is caused by the lattice areas, patches we see here, which are integrated with atrophic folds. And when we did the OCT, it showed neurosensory retinal detachment, as confirmed here as well. So the first poll question would be, what would be the next step? The parasplana vitrectomy, vitrectomy with scleral buckle, segmental scleral buckle, and encircling scleral buckle.
So we'll give that a couple seconds to run there, Mohamed. Thank you.
Mohamed, where did you say the breaks were?
So there was bands of lattice. They were around 2 and 4.
There's one option that's notably missing from the list of ways of fixing a retinal detachment.
Yeah.
I have a feeling that's intentional. There's your
yeah,
Peter,
there were inferior breaks, like if you go back to the picture, but I certainly would do pneumatic first line in most detachments in this age group as well. But there was kind of lattice all over, and there were breaks inferiorly as well. I can't remember the specifics of why I didn't do a pneumatic in this case, but
because I can see, I mean, she's obviously got a chronic detachment, but yeah, you can see lattice at around 1 o'clock, but
yes,
but the Optos probably doesn't capture everything.
Yeah, exactly. Just based on the location of the breaks, we didn't attempt a pneumatic first line, and in a case like this, there would have had to be fluid and holes inferiorly, like at 536, 630, that kind of thing, for me to have not done a pneumatic here.
Rajiv, this is like heresy after hearing your talk to the ASRS.
All right, Mohamed, the floor is yours again.
So the surgical decision was made to pursue a sutureless periotomy sparing scleral buckle. And before talking about the procedure, it will go in a little historic background on scleral buckle, which was first described in the 1940s by the German ophthalmologist Ernest Custodis. And after that, for a few years, he reported his case series of over 500 cases with successful reattachment rate of around 80%. Now, the numbers have significantly improved with the modifications after that, reaching to up to 95%. And the first ever implant was named after him. The few other modifications that were there at the time, in the few years, the same few years, the American ophthalmologist Charles Shepins was also involved in describing the scleral buckle, which is for the first time, the circumferential band. And later on, Harvey Linkoff further improved the procedure by changing the implant material, mainly due to causes of complications. So there were cases of extrusion, endophthalmitis, and inflammatory reaction that come due to the first implant that was ever introduced. And here we have an example. So the Custodius global implant, we see it here in the right top corner. And the figure down shows the first silicone sponge implant that was discussed or introduced by Harvey Linkoff. And on the right-hand side here, we have the two different types of material. This is not in keeping with all of the materials that are available, but shows us the examples of how things have evolved.
Mohammed, if I can just chime in there, I think that it's great that you looked into this history in detail, because you can learn so much from what was done in the past. And the Custodis, deserves a lot of credit, because he was the first one not only to do a scleral buckle, but also to recognize that you did not need to drain subretinal fluid, which was traditionally the method used to treat most retinal detachments, even prior to scleral buckling. So all of the techniques that had come before that were working to some extent involved external drainage of fluid. And whether that involved injection of air, by Ohm in 1911, or whether that in the Gonan procedure, where they, something called ignipuncture, where they took a hot metal device basically and went through the sclera, into the subretinal space, and essentially caused the retina to incarcerate at that site, with drainage. And then the heat kind of allowed the coagulation, also closed the break. All of these techniques relied on subretinal fluid drainage. And it was assumed that you had to get rid of that fluid for the retina to attach. So in addition to introducing scleral buckling, he also introduced the concept that you don't need to do anything to the fluid. The fluid will go away when you close the break, which was a really profound thing that effectively paved the way for pneumatic retinopexy, non-drainage scleral buckle, and other techniques now that become more prominent as we find out that not draining the fluid has many advantages.
Go ahead, Mohammed.
So before talking the procedure that was done, here are a few considerations in the traditional way of doing it, to involve the limbal periotomy, and then there is the muscle isolation, which is used by the muscle hooks, and then that follows that the identification of the breaks. The next would be retinopexy, whether that would be by laser or cryo, and lastly the conjunctival closure. Few potential post-op risks that has been described in the literature include diplopia, refractive changes. There's a small risk of glaucoma, sometimes due to steroid response, especially in children, dry eye disease, conjunctival scarring, and the cosmetic appearance after the procedure. And here we have the video of the procedure. I'm not sure if we have time to go over the full video. Okay. So here in the beginning, we see that there is a transconjunctival approach of isolating the muscles.
So, you know, what we're doing here is we're just grabbing the muscles with a forceps transconjunctivally and lifting the muscle up and trying to pass the suture with the needle on, the 2O silk suture, underneath the muscle. And then we're using force ductions to confirm that we actually have the muscle rather than just tenons in conjunctiva. I wonder if any of our strabismus colleagues are on here, if they have a better way of doing this, but you know, this is probably the most tricky part of this variation to scleral buckling surgery that we're going to show. So then we, you know, we marked the break on the conjunctiva, and then we treated the break with cryopexy. And then it's not easy to see in this video, but essentially, instead of opening the conjunctiva, we just made 4 small radial conjunctival openings in the location where we wanted to put the belt loops. And we created the 4 belt loops in those small conjunctival openings. And then here you can see we're passing the scleral buckle. And what we're doing is we're passing it through each belt loop. And then we are taking a, you know, essentially like a snap and passing it from one radial incision under the muscle to the other radial incision. And then we're passing the buckle around that way. And so, you know, what we thought was that this would allow you to do an encircling band without opening the conjunctiva significantly, other than the 4 small radial conjunctival incisions. And, you know, I know we as retinal surgeons often don't think about the conjunctiva a lot, but, you know, it's always been so kind of apparent to me, like that in some ways scleral buckling is such an elegant procedure from the internal aspects that you close the break and the detachment resolves, but it's pretty barbaric on the outside in terms of the conjunctival opening, the dissection of the intramuscular septum, the looping of the muscles. Sometimes we're fairly rough and torquing the eye quite a lot, draining, cryo. Like it is a pretty invasive procedure from that perspective. And so this was an attempt to circumvent a lot of the tissue dissection. And, you know, I thought that in a 15-year-old not opening the conjunctiva or doing any of that and getting an encircling band around would, you know, that would be a lifetime of potential issues that you could avoid.
So here here's the Optos post-op picture showing the band and the areas of the retinal scar where cryopexy was applied. And there is the OCT postoperatively showing improvement of the subretinal fluid and reattachment of the retina with the residual subfoveal fluid. The visual acuity improved to 20/50 postoperatively. And here we have the day 1 picture after the procedure. And we see the subconj heme is not as 360 as in the traditional procedure.
Yeah, I mean, this picture is not a great, this was, I think, on day 1. You know, we still had to, you know, you're still manipulating the tissue and you're still grabbing the muscles. So you're going to expect some chemosis, but there wasn't that like periorbital edema that you get a lot there, you know, and certainly there was the recovery. It's too bad we don't have the post pictures, you know, Miguel, we should get those, but, you know, as things just recovered much faster. Like the eye was looking normal at day 7, essentially. So, you know, I think that, that was kind of what we thought. Yeah, so go ahead, Mohammed. I don't want to cut you off.
Rajiv, that's congratulations. It's a very novel and elegant procedure. I mean, in the areas where you opened up the conjunctiva to pass the buccal, did you need to close those with sutures, or did you just let them close by secondary intention?
Yeah, sure. Mohammed, do you want to talk about that? How we closed it?
So for the closure, if you can see here in the video, cyan glue was used to close in this the conjunctival opening that were made initially to pass in the band.
So we used to seal glue, like we wanted to make it sutureless, but it didn't have to be sutureless. You could just put like 4 little vicryl sutures for each of the conjunctival openings. But we just like the idea of using 0 sutures in the scleral buccal case. And there was some like it's not as easy as it looks. Like everything in life, and as we did more of these cases, it got better. But initially, there was some tissue trauma locally. As you're trying to do all of this through a small wound. Sometimes it's harder, right? Because you're trying to pass things and get the snap out through the other radial incision, and so that's a lot of kind of instrumentation in those small spaces. So we probably don't have the exact right way of using the there's probably better ways of doing this with finer instruments, I would say. But yeah, I think that so at the beginning, the conjunctiva was a little more ragged, I would say, and so the glue was nice in cases like that. But I think as you improve your technique, you'll have a nice little opening there, and you can just use 1 vicryl suture. But yeah, so either suturing or to seal glue, and I think even leaving it open is a possibility. We worry about when you don't close the conj properly that the buccal can extrude in the future. Obviously we don't want to get an infection or anything, but the size of the wound is probably about 1 to 2 millimeters, and it's fair, or I shouldn't say 1 millimeter, but probably 2 to 3 millimeters snip in the conjunctiva and tenons right down to sclera. So that's fairly posterior. We're talking about 3 or 4 millimeters posterior to the muscle insertion. So it's possible that you wouldn't have to even close the conj, although I didn't feel like doing that at this stage in the game with this procedure.
And Rajiv, timing wise, do you think how much, presumably you've done some more, but compared to a regular scleral buccal, how does this take longer? Does it take less time?
Yeah,
I would guess longer, but
yeah, it's a little longer. Yeah, so it's probably 5 to 10 minutes longer than it takes me, and so
not much longer.
It's not much longer, but it's longer for sure. It's a little bit of a more of a pain in the butt. So because you're trying to preserve all that conjunctiva, and you're making your life a little harder by not opening everything up. And so yeah, I'm sure you guys if others are interested, we'll find even more elegant and efficient ways to do this with minimal tissue trauma, and you'll find ways to make this easier as you do more. Like we've probably done like 5 cases, I would say, at this point. I've done it not just for primary buccals, but it's really it's really elegant in VIT buccals for like elderly patients, because their conj is so thin that you can actually loop the muscle fairly easily transconjunctivally. But yeah, as you're going to go through this, you don't want to tear the conj and end up having these huge openings anyway. So it's just really practice, and how to handle the tissues. But so it does take a little more time, for sure, and I think a little more care, and but our question is it worth it? I think that's what time will tell.
I mean, kudos to you for pioneering this work in pediatric patients, because with the tenons being so much thicker, it's probably a much more challenging dissection with greater challenges for hemostasis.
I would just like to add a few points as while Muhammad is going through his presentation. As Dr. Slomovy was pointing out, there is good evidence that show from strabismus surgeries that show that the use of bicrete sutures can cause more redness and irritation, and this has been proved from in randomized controlled trial. So sealant fibrin is a good option to decrease the redness and irritation, and that's what we are seeing in this case. And the other thing that we want to emphasize with this is that vitreoretinal procedures has been shown to decrease the number of global cells, and global cells are very important in patients, for mucin production and tear film quality, and this decrease the chances of having dry eye syndrome, and especially in this pediatric population that are gonna go through their life with this buckle in their eyes. So it's really important to avoid the decreasing the global cell population, and this strategy of preservation of the limbal peritomy is very important in order not to decrease the global cell numbers.
As a counterpoint, though, I mean, the fibrin glue is not inexpensive. It's also a pooled plasma product. So I think, we have to be at least aware of the fact that, there can be infectious agents with at least historically with those products.
That's a good point, Dr. Reng, and we can also use autologous blood to try to emulate what fibrin sealant does. So that's an alternative as well.
My biggest concern with this technique is that you split a muscle and don't pass the buckle under the muscle fully. So what I've been doing is I'm really hugging the sclera the whole time. So I enter one radial incision and essentially push down on the sclera and then pull up the muscle with the suture and really pass it through. And I want that smooth passage without. But that's what I'm concerned about, and we haven't had any cases of diplopia or any issue like that. But that's kind of what I'm really looking out for, with this technique.
Well, thank you, Mohammed. I think the floor is yours again.
So when you go back into the literature, the first time this technique was described was in 2014, which would be around 40 years after the lumbar periotomy was described as well in the 1970s. And then in their report, they did that for 46 eyes and had successful segmental scleral buccal position. And the same anatomic consideration or procedure consideration would be really transconjunctival muscle isolation and wound closure with glue or suture. We have here our second poll question, which might be related to some of what Miguel has said. Which of the following is true? Conjunctiva in children is thicker, conjunctiva in adults is thicker, lymphoid tissue aggregate is low in children, lymphoid tissue aggregate is the same in children and in adults.
All right. We got overwhelming consensus here, so I'm going to end the poll quickly.
So we'll answer that question. To answer that question, we'll go over some of the potential benefits that were discussed in the literature. First is, as Miguel have talked, there would be limitation of limbal anterior segment or anterior conjoint tenile scarring, which would improve or lessen the risk of ocular surface disease. A second point is the risk for failure for secondary procedures or treatments would be better, as in the case of revision of buccal implant, paraspinal vitrectomy, and if the patient develops glaucoma and needs any filtrating surgeries. With the conjunctiva being thicker in children, the reason behind that would be for the higher lymphoid tissue. And this in turn, when using sutures, which are dissolving by the drive behind the inflammatory reaction, this may cause some inflammation and scarring in children. And the last point that was discussed in the literature was the postoperative cosmetic appearance. The last point was also described in the literature by 2 other reports that showed like 10 eyes showing successful primary reattachment with segmental buccal, and only 50% showed subconj heme, and the other report by Gao showed 15 eyes as well with successful reattachment. There hasn't been a quantified data on the ocular surface disease or reports on the secondary glaucoma procedure, but the idea behind it is that it goes on and decreases the scarring, which is a risk factor for failure in those procedures. And I'll hand here to Miguel.
Miguel, so maybe you can just take a minute or two and wrap it up so we have time for Jovi's case.
Yeah, so we just want to summarize that the potential benefits of this technique, as we mentioned before, are, importantly, the preservation of the global cells. We know that the global cell population can decrease up to 40 to 60% after vitreoretinal procedures. That includes vitrectomies, and that includes scleral buckles, and this is attributed to conjunctival trauma. So with these techniques, we're just aiming to minimize the conjunctival trauma and just increase the quality of life of our patients through their life. And the other thing that we want to point out is that, especially in pediatric population, these patients will have a higher risk to develop glaucoma. Some of these patients with retinal detachment in the pediatric population will have trauma-induced retinal detachment, and that itself can later on cause progress to glaucoma. So it's important to preserve the conjunctiva for sequential procedures such as trabeculectomy. And as Mohammed was mentioning, the scarring of the conjunctiva is the main risk factor of trabeculectomy failure, leading to up to 50% of the trabeculectomy failure in patients with previous ocular surgery. And those are mainly the points that we want to address, by encouraging the use of this technique with limbal sparing peritomy. And also we want to address that everything that we do in medicine is an evolution, as Mohammed was mentioning on his talk. It took 40 years since the description of the 360 limbal peritomy by King and Skeppens and others in the 70s to evolve to this limbal peritomy procedure that we have been seeing since 2014 and 2019, and now with our case. So that's a very important point for the residents, that to see how things are evolving in our field. And as Dr. Mooney was mentioning, we want to push everyone to keep the evolution in the field.
I mean, it's a very cool technique. I mean, it's a bit of a leap, though, to say that this doesn't necessarily reduce goblet cell density, right? We don't really know that, because there's still conjunctival dissection, there's still conjunctival trauma, there's still a foreign body. But I mean,
yeah, definitely
something to study going forward.
Yeah, exactly. And, maybe as Jovi's getting her slides, I can just add a few comments that, so we sort of came up with this idea independently, but then as with most things in life, others have thought about it as well. And we found this South American group that had done 10 cases with a very similar procedure. So, what we're trying to do now is like think about the whole concept and see if we can make it better and more efficient, and then also do some of the studies that Ken is alluding to, and maybe that can be our contribution from U of T, in trying to validate it and show how it can reduce some of these symptoms after scleral buckling, and maybe some of the metrics like the tear film, other metrics. We can talk to Alan maybe about it and see what we should be looking at, but just trying to move it forward a little bit is our goal now, I think.
All right, thank you, Joe. Thank you, Rajiv. Jovi, the floor is yours.
Wonderful. So I'm Jovi Wong. I'm a PGY4. at the University of Toronto, and I'm really excited today to present about minimally invasive repair of giant retinal tear associated retinal detachment. And of course, in this grand rounds with Dr. Mooney, we can maybe guess what the minimally invasive repair will be. So I'm going to start right away with the poll. Let me just go ahead there. Perfect. So a giant retinal tear, or GRT, is a full thickness retinal break defined as a tear that spans greater than 1 clock hour, a tear where you're unable to see the full extent in one view using a 20 diopter lens, a tear that's greater or equal to 3 clock hours or 90 degrees, or a tear that's greater or equal to 6 clock hours or 180 degrees. And so for those of you who've never heard of giant retinal tears before, you can, as you know, just guess C.
It's always C, right?
Exactly.
That's the OCAP strategy right there.
Is
All
that
right,
why
so-
you read have done so well, Amandeep? They're always
Basically.
see when in doubt.
See when in doubt. So there you go. I don't know if you can see the results there.
Yeah, it sounds like people heard, so that's good. All right, we're having some trouble progressing the slides. Okay, there we go.
There you go.
So as we said, it's C. So let's do a quick overview about giant retinal tears. And there's a photograph from Dr. Cruz Pimentel on the top right. You see a giant retinal tear there on the Optus photo. But we should think of them differently from regular retinal tears. They're a separate and different pathological entity with special considerations. And compared to regular retinal tears, they can lead rapidly to extensive retinal detachment. As you can see on this large tear here, that there's a tendency for the edge of the flap to roll or fold. There's an increased risk of proliferative vitreoretinopathy with or without surgery, and redetachment is more frequent in these cases. There's a high risk for reoperation that will be needed. Also an increased risk to the fellow eye for retinal tears or detachment. And notably, this entity is much more common in males with a preponderance of 65 to 90% compared to females. And in terms of the classification of these giant retinal tears, there are two kinds. One which is based on location by Scott, and another that's based on etiology by Skeppens. And so the one based on location, we can consider the tears to be equatorial with posterior extensions, which has some higher risk for worse outcome and worse detachment, and oral being at the aura, and these are the least common. And under the Skeppens classification, we can classify them as idiopathic, which is the most common, or traumatic, a traumatic cause of giant retinal tears, lattice degeneration related, or iatrogenic. So indeed, you could have a giant retinal tear caused by another procedure that we've done or another surgery that we've done. Okay. So then, of course, you can have giant retinal tears as a tear on its own, but of course, it's heavily associated with a retinal detachment, and in particular, Rhegmatogenous retinal detachment. And so we just want to give a brief refresher on what this includes. And so this is defined as a break in the retina that allows liquefied vitreous to directly enter the subretinal space. So in this schematic, as you can see, some liquefied vitreous is entering this retinal break and then causing the detachment of the retina. And for the general ophthalmologist, some risks that we want to consider for retinal detachment include lattice degeneration, peripheral retinal breaks, pathological myopia, previous intraocular surgery, trauma, of course, previous retinal detachment, and a family history of these problems. And as we discussed scleral buckling in the previous talk, here we also want to mention the wide range of management options now includes pneumatic retinopexy, scleral buckling, parslane vitrectomy, of course. For subclinical detachments, we could use laser demarcation, we could use combined procedures of the above, and then of course now emerging technologies such as in-office suprachoroidal viscopexy. So then we're moving on to the most common method of repair for Rhegmatogenous retinal detachment, and this is the pars plana vitrectomy. And so for those who don't know the steps of this procedure, we just have this helpful video from the AAO. And so first, we have placement of trocars into the eye, and then we want to remove the vitreous, which is replaced with balanced salt solution. And then afterwards, we need to flatten the retina. So it's possible that we may need to use heavy liquids like perfluorocarbon, especially when we're talking about giant retinal tears. And we'll have a video of that later on. Then we have to replace the saline with gas and apply laser retinopexy to all the breaks. And finally, we tamponade with either a long-acting gas or silicone oil. Of course, it's a very brief overview, but so everyone has a general schematic. So this brings us to our next poll question. And this one's a bit longer, so I'll get started reading it. But essentially, what is the reason for increased risk of proliferative vitreoretinopathy in giant retinal tear-associated retinal detachment? So as we mentioned, this is one of the additional risks with giant retinal tears compared to just regular retinal tears. And so is it vitreous hemorrhage associated with giant retinal tears causes membrane formation, exposure of larger amounts of RPE cells to the vitreous, causing epithelial to mesenchymal transformation and membrane formation, the associated need for cataract surgery shortly after giant retinal tear repair, or intraocular pressure associated complications. And for this one, usually the longest answer is the right answer. Wow, so
The audience got it.
excellent. So everyone knows already. Okay. So there are some challenges with using pars plana vitrectomy for giant retinal tear associated retinal detachment. It's so long, so we have to use a few letters. Uh-oh, gave it away. But essentially, one of the issues is, there's often a need for long-term tamponade, such as with silicone oil. As we mentioned, there's this increased risk of proliferative vitreoretinopathy because of the increased exposure to the RPE, to the vitreous, and that, incorrect anatomical exposure causes the RPE cells to transform from epithelial cells to mesenchymal cells, and then that seems to promote the formation of these fibrotic membranes. That makes the retina stick together, scar, and have additional challenges for repair and poor outcomes. The other thing we want to mention is that there's a need often for a perfluorocarbon liquid, which is a heavy liquid to push down and flatten the retina during these procedures. And then this liquid is toxic to the retina if it ends up subretinal. And so this risk is present if this is the main method of repair. And so, of course, this allows us to consider whether there could be other options for repair of giant retinal tears and their associated detachments. So no talk with Dr. Mooney is complete without an overview of pneumatic retinopexy. So here is an AO video on pneumatic retinopexy as a method. And so how we do this is, first, they don't include this, but we have to make some room. So we do a paracentesis of the anterior chamber of 0.3 mils or more, followed by this intravitreal injection. And in our case, we most often use pure 100% sulfur hexafluoride. And then the patient must position their head to ensure the gas bubble covers the break. So the gas will float and they have to position their head to the correct spot. Then they're going to come back the next day or 2 days later for laser retinopexy, which is our preferred approach once the retina is flattened. You could also use cryo, which is what they showed in this video, but we tend to use laser. And then the gas will reabsorb over the next 7 to 10 days if we're talking about SF6. Okay, and of course, we want to mention the data we have on using pneumatic retinopexy for repair of regular retinal detachments. Sorry about that. And of course, we have the PIVOT trial, which compared pneumatic retinopexy versus pars plana vitrectomy for primary repair. And an older study had compared pneumatic retinopexy versus scleral buckle for primary repair. And in particular, these studies, we included patients with breaks that are causing the detachment that are in the superior 2/3 of the retina. So between 8 o'clock to 4 o'clock, where the single break or group of breaks is no larger than 1 clock hour. And both studies were remarkable in showing that there's reduced morbidity with pneumatic retinopexy, and there's also improvement in the final visual outcome compared to pars plana vitrectomy. And it's just included here on the right-hand side, the inclusion and exclusion criteria for the VIVID trial, and essentially that the recommendation for patients who meet this criteria would be that primary repair using pneumatic retinopexy would be recommended. So, of course, this finally leads us to the question of, could we use pneumatic retinopexy to repair giant retinal tear associated retinal detachment? So here I'm going to go through a case of where this exactly was done. So we have a 60-year-old gentleman. He had a visual field defect for 1 week, visual acuity of 20/70. He had a fovea on folded over a giant retinal tear, associated retinal detachment from about 10 o'clock here. At 2 o'clock, there is a horseshoe tear, which you can kind of see in this photograph here, at 7 o'clock, and then a few at about 6 o'clock in parts of the retina that are attached. And so laser retinopexy was applied to those attached retinal tears first before the pneumatic, and 0.7 mils of SF6 was injected. The patient was asked to position face down for 6 hours and then steamroll, which is a method where the patient gradually elevates their head until they reach the final head positioning. And so you see in this remarkable Optos photo the extent of the giant tear and the fact that it's folding over. So here's day one. Once the gas has been injected, you can see a nice large bubble here in the vitreous, and then we've already started the laser retinopexy, and Dr. Cruz Pimentel wanted to mention the fact that it's important that we start the laser right away on day one rather than often waiting until the second day to start the laser. So you can already see some laser marks that have been applied. And here on day two, we have already completed the laser. So you can see how big the tear really was and how the gas is supporting it. Then at 6 weeks, you can see, so the gas has been reabsorbed and retina's nicely attached. These are the laser scars that you can see, spanning the extent of the tear. And then at 2 months, you have a nice flat retina. The final visual acuity is 20/50, and we wanted to show the associated OCT over the macula and fovea, and mention, that there's very excellent integrity of the structure here, where you have a very flat retina. There's no wrinkles or folds, really good foveal contour as well. And so I'll pass this on now to Dr. Cruz Pimentel, who's going to tell us a bit more about using pneumatics in giant retinal tears and their associated detachments, and then 10 years of data on this.
Thank you, Yovi. So traditionally, GRTs has been considered a relative contraindication for pneumatic retinopexy. However, in the light of excellent anatomical and functional results that has been proven by randomized control trials such as the PIVOT trial, which will think about the use of pneumatic retinopexy in giant retinal tears are these. We can go to the next slide, please. So here we have a typical intraoperative view of a folded over GRT. Is something that we see very often in vitreoretinal surgery, where we have to use PFCL to unfold these folded over GRTs. And as you can see, one of the intraoperative complications that we can face are these posterior folds affecting the fovea and the macula. And these, very often we see it. So here we're trying to use maneuvers to unfold this fold. We were able to do it by using the back flush cannula, and we were able to unfold it. But you can see how much we're stretching the retina to get rid of this fold. And so these are the things that we need to consider as vitreoretinal surgeons to avoid in our patients. Then we elevate the level of perfluorocarbon liquid, and we finally are able to perform the laser around the edges of the giant retinal tear. But certainly these complications intraoperatively can happen in patients with these folded over GRTs. So as Joey was mentioning, some of the strategies that we need to use in the treatment of giant retinal tears with treated with pneumatic retinopexy is applying laser prior to the injection of the gas, and laser must be applied to the horns if the horns are attached, and this is something that Dr. Mooney highly recommends for this population of patients. Also a steamroll maneuver, as we have seen in our previous case, is very useful to unfold GRT. So another classification of giant retinal tears is folded over and not folded over giant retinal tears. So people don't talk about folded over giant retinal tears very often. How to manage those with pneumatic retinopexy. Skepens did observations, and he found that the process of folding over of a giant retinal tear happens between the first 12 to 48 hours after the giant tear occurs. So this is why it's very, very important to treat these patients early, because the faster we treat these patients, the easier we can unfold these tears. So as we presented in the case, a steamroll maneuver is usually enough to unfold these folded over giant tears, and this is based on the buoyancy force of the gas bubble. And also sometimes we recommend alternate head position. In some cases, it's useful to tamponate both edges of the tears as we are progressing with the laser retinopexy. And very important in this population is to reassess the patients in the first 24 hours, not only to start the laser, but also to see if there is need to change the positioning. Or also, we like to do sequential gas if it is needed, and usually the sequential gas injection will be done within on day 3, within the first 3 days. But it's important to tell the patients before the procedure that because of the extension of the break, sequential gas injection may be needed in this population. Next. So here we have an example of how to treat the horns of the giant retinal tears before we place the bubble. And here you can see that usually one of the horns will be attached, and that is enough to perform laser and to prevent, and this is a strategy to prevent enlargement of the giant retinal tear. As you can see here, we did the laser around the horn pre-placement before the placement of the bubble, and then after the placement of the bubble, there is no extension of the tear beyond the margins of the previous laser. You can go to the next one, Joey, please. So here's another example of a patient with a giant retinal tear successfully treated with pneumatic retinopexy, and this is the result that we can have after treating these patients with pneumatic retinopexy. Can you go to the next slide, please? We want to present our data from Dr. Mooney's patients treated with pneumatic retinopexy at St. Michael's Hospital. This is a 10 years data, including consecutive case series of patients with giant retinal tear associated retinal detachment. And we have 31 patients that were included in this study. And the primary anatomic reattachment with pneumatic retinopexy was achieved in 60.12% of the patient. 12 patients required vitrectomy for failed PNR, pneumatic retinopexy, and final anatomic attachment rate was 100% in those patients that even require a vitrectomy. But very important in this cohort, what we found is that only 2 patients needed the intraoperative use of PFCL. And why is this? Because even if the pneumatic retinopexy failed, you're converting the tear and you're reducing the extension of the tear. Let's say you start with a tear that is 6 clock hours or 180 degrees, and then you're able to reduce it to a 3 clock hour tear. So you basically reduce the need for carbon liquids intraoperatively, even if the procedure failed, and you avoid complications such as the one that we presented previously. And interestingly, no eyes require silicone oil as a tamponade, and the visual acuity overall improved from 2400 to 2080. Go to the next slide, please. So this is the pre-op picture of the case that we presented in the video, where we have this intraoperative full while we were using perfluorocarbon liquid. You can go to the next slide, Jovi, please. And here is how nicely it looked after we fix it in surgery. And in this case, we use perfluorocarbon, as we mentioned before, as we shown before, and also we use silicone oil as a tamponing. Can you go to the next slide, please? However, you can see here in the OCT, the early post-op OCT, the so-called omega sign, and this sign is just telling us that it's subretinal perfluorocarbon in this patient. So this is another complication that we can see when we use perfluorocarbon liquid in patients with giant retinal tear. So again, using pneumatic retinopexy is a minimally invasive treatment that needs to be considered in the treatment of these tears to avoid these complications. But there are also another intraoperative complication that is called slippage, which is the displacement of the retina when we reduce the level of PFCL. So I'm gonna pass it on to Dr. Mooney now to elucidate more on this complication.
Great, so I'm just gonna share my screen here. Can you stop sharing, please? And
Now, as he does that, Miguel, question for you. You know, how do you prevent, or what's the risk of the pneumatic bubble going subretinal here?
That's a good question, but usually because you know, when we try to inject just one bubble, we try to avoid having fish eggs. But once you put the patient face down, basically as the patient is doing a stent roll, it's very hard for the bubble to go subretinal. But we don't know exactly what is the risk. We haven't seen it in this cohort, but that's, you know, that's something that we're exploring to explain with mathematical models, because we believe that the cohesion, the surface tension of the gas is enough to maintain the gas bubble together and to avoid going into the subretinal space.
I think the important thing also is that the gas can go subretinal, but easy come, easy go. You know, it's easy for it to go under, and it's easy to get it out as well with the GRT. So, you know, you can see how things are going and adjust positioning accordingly. So I'm just going to end very quickly just to show you some of the physical properties that, you know, we've learned about. And GRT pneumatics, I think, is a Toronto thing as far as I know. And kudos to Peter, who I think has brought that here. Because, you know, there may have been the odd case report, but I'm not aware of anywhere in the world where GRTs are being treated with pneumatic in high frequency. And I think that that's something that Peter, with his, you know, really greatly expanded, I would say, the indications for pneumatic, you know, here in Toronto, and that's kind of led us to, all of us, to do it and to learn about it. So this is a picture showing you a simple retinal detachment where, you know, we injected a gas bubble, and I want to show you this picture because this was an Optos at baseline and then 1 minute after the gas injection. And look at how the buoyant force of the bubble essentially displaced that fluid almost immediately. And this should show you the power of a gas bubble, like how much buoyant force what it can do to the retina. And I think this is the kind of misunderstood aspect of GRT repair with pneumatic retinopexy. Here's another example. You put the bubble in, 1 minute later, there's a massive reduction and movement of that subretinal fluid. You know, we've spent a lot of time studying retinal displacement, and it's very important to understand the pathophysiology because that'll help us understand slippage. So, you know, what happens is with retinal displacement is you have a buoyant force of the gas bubble, and like we just showed you, it's very substantial. And that buoyant force of the bubble forces fluid, any residual fluid that's left behind at the end of surgery gets shifted from the buoyant force of that bubble. And as that forced flow of fluid occurs under the thin elastic retina, that leads to a stretching of the retina. So here's another cross-sectional view showing that subretinal fluid being displaced inferiorly by the buoyant force of the bubble. And that flow of fluid causes a drag and a stretch of the retina, and that's what retinal displacement is. Now, slippage is very different. So in some ways. So in this example of a GRT, you put perfluorocarbon liquid in, the fluid goes up anterior to the retinal break. And then as we know, we try to drain very meticulously at the anterior aspect of the break to take away any amounts of fluid, but you can't get it all. And so what happens is even if there's a sliver of fluid, as that fluid migrates posteriorly when we're taking out the PFCL, you'll get redundancy and slippage. And slippage is kind of like the opposite of displacement. In displacement, the fluid is moving from posterior to anterior inferiorly, and as it's moving, it stretches the retina and the macula, and you get redundancy in the periphery. Slippage is the opposite due to the iatrogenic movement of fluid intraoperatively, where fluid is moving from anterior to posterior. And so instead of getting a stretch posteriorly, you're getting redundancy because all the fluid's ending up posteriorly, and you would get stretch anteriorly. But because there's a huge tear there, you get slippage. If there was no large tear, you would get a stretch anteriorly and the redundancy posteriorly. So it's kind of just where the fluid's moving from point A to point B, which determines are you getting displacement in the macula or slippage and folds in the macula. So, you know, what is really cool about GRT and pneumatics is that you don't even actually have to cover the retinal break. You know, because a lot of times you're wondering, well, how did a 0.6 cc bubble cover that 6 or 7 clock hour tear, let's say? It didn't. You know, all it did was by putting the patient initially face down, the buoyant force of the bubble causes this huge movement and egress of fluid out from the break, and the face down positioning automatically makes gravity unroll the giant retinal tear. And then often you're surprised 20 minutes later, an hour later, the retina has been largely attached. And the next day, even parts where you never covered with the bubble are attached and you can laser. So this is an example of where, you know, our traditional thought of pneumatic tamponading the brake is actually not the main mechanism that's allowing the early reattachment of large parts. You know, as we move forward and you get some of it attached, yes, you need to tamponade the horns in some aspects, but I think an understanding of the physical properties here has really allowed us to kind of innovate in the thinking around GRT repair. So I think we'll end there because it's 8:30, but I don't know if there's any comments or questions by the other retinal surgeons or anyone else.
Yeah, those were great. Those are great rounds, Rajiv. I think the other point that, you know, it does, you know, nothing fixes detachments 100% of the time, but, you know, a pneumatic for a GRT, even if it doesn't work, it often makes the surgery considerably easier, you know, because, and reduces the risk of, you know, if you choose to use perfluorocarbon liquids, reduces the risk of, subretinal perfluorocarbon, reduces the risk of, you know, a retinal fold or slippage. So even if it doesn't, even in the event that it doesn't work, which happens not infrequently, it's still useful. It's still a good start.
Yeah, I agree.
Okay, well, thank you, everyone. So I want to thank Jovi and Mohamed for their presentations. Miguel, I think you've done a lot of work in this area. It shows. So congratulations on all the work that you're doing. And Rajiv as well. You know, we mentioned earlier you won a lot of awards for your research in this area over the last couple of years, and it makes us very proud as a department. So keep up the strong work. I do want to thank everyone for joining us for the first rounds of the year. And we do have a visiting professor next week, Dr. Ian Clark from Winnipeg, a pediatric ophthalmologist. So I hope to see many of you then. Enjoy your Friday, guys.
Thank you, everyone. Take care.
Bye.